When your doctor tells you that you need surgery, it's natural to treat that recommendation as a final verdict. We often assume that if a procedure is suggested, it must be the single best path forward. But a surgical recommendation should actually mark the beginning of an informed conversation, not the end of one. Think of your body less like a birth certificate and more like a classic airplane. Two planes built in the exact same year can look completely different under the hood depending on their maintenance and the structural strength they have left, what doctors call your functional reserve. When considering a major operation, this internal resilience matters far more than the number of candles on your birthday cake. This isn't about avoiding necessary medical care. It's about making sure the treatment truly protects your long-term independence and quality of life. Today, we are exploring 4 common, high-stress procedures that routinely demand a second opinion. By understanding your personal risks, you can move past passive compliance and become an active participant in your healthcare decisions. Let's examine the critical questions you should ask before signing any consent form. To truly understand how a major surgery impacts your body, we have to look past the date on your birth certificate. When a physician evaluates you for a procedure, they are looking at 2 entirely different timelines: your chronological age and your biological age. Chronological age is simply the number of years you've lived. But biological age reflects the true condition of your internal organs and tissues. Think of your body's systems like a structural foundation. 2 homes built in the same neighborhood in the exact same year might look identical from the street. But underneath, one may have solid, unyielding support beams, while the other has beams that have slowly weathered and weakened over time. In medicine, that foundational strength is called your functional reserve. It is the extra biological buffer your heart, kidneys, and lungs keep in storage to help you bounce back from severe stress, like a major illness or an operation. When you undergo an invasive procedure, your body relies entirely on this functional reserve to heal. This is wherever the concept of medical frailty comes into play. Frailty isn't just about feeling tired or moving a bit slower. It is a measurable medical metric that tracks how much of that internal buffer capacity has declined across multiple organ systems. A landmark review published in JAMA Surgery looked closely at how preoperative frailty impacts surgical outcomes. The researchers discovered something profound. A patient's frailty score is a significantly more accurate predictor of post-operative complications, long-term institutionalization, and overall survival than their calendar age alone. This means that a robust 75-year-old with deep functional reserves might sail through a procedure that presents immense, life-altering risks to a frail 65-year-old. Every individual situation is entirely unique, which is why an operation should never be recommended based on your age alone, but rather on how much structural resilience your body has left to handle the stress of recovery. Let's look at the procedures where this internal reserve is put to the ultimate test. Starting with number 1, multi-level spinal fusion involving instrumented hardware, when severe chronic back pain makes every step a challenge. The promise of a surgical fix sounds incredibly appealing. The goal of a fusion is to permanently lock 2 or more vertebrae together using metal rods and screws to stop painful movement. For certain conditions, like unstable spinal fractures or progressive nerve compression that threatens your ability to walk, this intervention can be absolutely vital and life-changing. However, when it is proposed as a routine fix for age-related degenerative disc disease, and the long-term reality can be vastly different from what patients expect. The human spine is designed to distribute mechanical stress evenly across its entire length. When a surgeon steps in and completely immobilizes several segments with rigid hardware, that kinetic energy doesn't simply vanish. Instead, it gets forced directly onto the healthy, unprotected joints immediately above and below the fused zone. This creates a well-documented medical phenomenon known as adjacent segment disease, because those neighboring tissues are suddenly forced to absorb an unnatural amount of mechanical load, and they can degenerate at an accelerated rate. This frequently leads to a return of the exact same pain and, all too often, the need for additional surgeries. A comprehensive study published in the Spine Journal tracked older adults who underwent these complex lumbar fusions and found that major complication rates reached nearly 38%. Crucially, the data revealed that many patients did not achieve superior pain relief or better physical function compared to those who chose structured, non-operative physical medicine. For some individuals, surgery remains the safest path. But given these heavy biomechanical shifts, taking a step back to explore conservative, high-quality physical therapy is a deeply protective first step. Moving on to the next, The second procedure that demands this level of careful scrutiny takes us directly into the chest cavity. Traditional open-heart interventions requiring a central cardiopulmonary bypass machine. For decades, open-heart surgery has been the gold standard for repairing blocked coronary arteries or replacing diseased heart valves. When a patient is facing an acute, life-threatening blockage, opening the chest to restore blood flow is an extraordinary life-saving capability, but we must acknowledge the immense physical toll the procedure exacts. To allow the surgeon to work on a perfectly still heart, your blood circulation must be diverted entirely to a mechanical pump. While this heart-lung machine keeps you alive during the operation, routing your entire blood volume through plastic tubing and mechanical oxygenators triggers a massive, full-body inflammatory cascade. This intense inflammatory response, combined with subtle changes in blood pressure across your brain's delicate microvascular networks, places a profound strain on an older system. It is one of the primary reasons why some patients experience post-operative cognitive changes or temporary confusion during their recovery. Fortunately, modern medicine has advanced rapidly, giving us highly effective, less invasive alternatives. For instance, instead of cracking the breastbone open, physicians can often utilize catheter-guided techniques, such as transcatheter aortic valve replacement, or TAVR. This allows a new valve to be guided into place through a small blood vessel in the leg. These advanced, micro-invasive paths bypass the need for mechanical circulation entirely, drastically lowering the stress on your vital organs. Of course, these risks don't apply equally to everyone, and only your healthcare team can determine which approach aligns with your specific anatomy. If you are finding this information helpful, and you enjoy evidence-based health content that helps you make more informed decisions, consider subscribing to the channel. It also lets me know you'd like to see more videos like this. Moving deeper into major abdominal interventions brings us to our third high-stress procedure, extensive oncological resections, such as the Whipple procedure for upper gastrointestinal cancers. When a cancer diagnosis is delivered, the immediate, natural instinct is to want the tumor out of the body as quickly as possible. In many cases, surgical removal offers the definitive cure. However, major abdominal resections involve completely altering your internal anatomy, removing portions of multiple organs, and meticulously rerouting your digestive tract. This demands an incredibly robust recovery process from your body. For older adults, the key is to look beyond the immediate success of the operation itself and focus heavily on what doctors call failure to rescue. This term refers to a medical team's inability to successfully manage a complication if one arises after surgery. Research published in the Annals of Surgical Oncology found that the risk of failure to rescue rises sharply in patients over the age of 75. This is particularly true when pre-existing heart or kidney conditions are already reducing their baseline functional reserves. This means that while a surgeon might successfully remove the tumor, the subsequent strain on the rest of the body can severely compromise a patient's long-term independence. True medical success should be measured by whether a treatment preserves your daily quality of life, not just by a clean post-operative image. This is why modern oncology heavily emphasizes shared decision-making. This is where you and your family sit down with your specialists to explicitly weigh the realistic survival benefits against the physical cost of a highly invasive reconstruction. Our fourth high-stress area involves planned total joint replacements, specifically major structural overhauls of the hip or knee when a patient is managing multiple chronic, comorbid conditions. Joint replacements are incredibly common and remarkably successful at restoring mobility to millions of people suffering from severe arthritis. But the joint itself does not exist in a vacuum. When a patient has an advanced underlying metabolic or vascular condition, and the systemic risks of a joint overhaul change dramatically. The primary challenge with a major orthopedic replacement isn't the new ceramic or titanium joint. It is the prolonged immobility that follows the procedure, combined with the body's natural blood clotting response to bone surgery. For an individual managing pre-existing cardiovascular disease or poor circulation, this temporary lack of movement significantly escalates the risk of deep vein blood clots and post-operative pulmonary complications. Furthermore, if a patient's baseline mobility is already severely limited by other health factors, A joint replacement might not deliver the dramatic return to independence they were hoping to achieve. For some people, surgery remains the absolute best choice to relieve excruciating pain. But for others, optimizing non-surgical management or rigorously preparing the body before entering the operating room can completely alter the recovery trajectory. This brings us to a highly empowering realization. You are never entirely powerless when facing a scheduled surgery. There is a profound difference between waiting passively for your operation date and actively strengthening your body through a concept known as prehabilitation. Think of prehabilitation as training for a personal athletic event. If you were going to run a marathon, you wouldn't spend the month before sitting on the couch. You would build up your strength, optimize your fuel, and prepare your mind. A major clinical trial published in The Lancet Healthy Longevity evaluated the real-world impact of a structured, 4-week prehabilitation program for high-risk surgical patients. The program focused on simple, targeted interventions, optimizing daily protein intake to preserve muscle mass, engaging in structured walking to boost lung and heart reserves, and carefully tracking nutritional status. The results were staggering. This short period of active physical preparation dropped post-operative pulmonary complications by 42% and significantly shortened total hospital stays. Beyond exercise and nutrition, a comprehensive pre-op strategy includes a meticulous medication audit with your physician to pause hidden over-the-counter supplements that increase bleeding risks. It also means maintaining excellent hydration and optimizing sleep. Even simple steps, like ensuring your glasses and hearing aids are handed back to you immediately in the recovery room, are proven to keep your brain oriented and drastically reduce the risk of post-operative confusion. Understanding when and how to advocate for yourself during a medical consultation is a skill that directly protects your health. It is vital to recognize the difference between a true medical emergency, where an immediate operation is required to save a life, and an elective or scheduled procedure where you have ample time to gather facts. For the vast majority of non-emergency conditions, taking an extra 7 to 14 days to seek an independent second opinion is entirely safe and standard medical practice. When evaluating a surgical recommendation, true collaboration with your doctor means focusing heavily on informed consent and exploring all available alternatives. This doesn't mean viewing your surgical team with distrust. Modern healthcare providers appreciate engaged, well-informed patients. Your goal is simply to make sure the proposed plan aligns perfectly with your personal definition of a good quality of life. You want to understand not just the structural goal of the operation, but what your specific day-to-day recovery process will actually look like given your unique health history. If you've learned something new so far, take a moment to like this video. It helps more people find evidence-based health information and supports the channel. When we look closely at these high-stress procedures, the ultimate fallout of rushing into surgery without evaluating your body's true biological age and personal frailty metrics becomes incredibly clear. Choosing a major operation without assessing your functional reserve can lead to a long-term cascade of unintended complications, a loss of physical independence, and a diminished quality of life. But remember, major surgery is not inherently good or bad. For many individuals, an operation remains the absolute safest and most effective option to protect health and restore daily function. The key lies entirely in personalized, informed decision-making. It means taking the time to ask your care team targeted questions, exploring less invasive medical alternatives, and actively building up your body's resilience through targeted prehabilitation when time allows. Every single patient's medical situation is entirely unique, and any major treatment path must be carefully customized in partnership with your personal healthcare providers. By actively shifting away from blind compliance, you protect your long-term independence and regain complete control over your health journey. Navigating a surgical recommendation can feel overwhelming. But remember, the ultimate goal is never to simply avoid surgery at all costs. It is to make informed, evidence-based decisions that protect your long-term health, independence, and true quality of life. Because every person's medical situation is entirely unique, these vital healthcare decisions should always be made in close consultation with qualified healthcare professionals. You have the power to step out of the passenger seat and become an active, confident participant in your own care. If you found this guide helpful, please take a moment to like the video and subscribe for more evidence-based health content designed specifically for adults over 60. Consider sharing this with a friend or family member who may be preparing for surgery. Or making an important medical decision right now, a little shared knowledge can make a world of difference. Before you go, I would love to hear from you in the comments below. If you or a loved one had to make an important surgical decision today, what question would you ask your doctor first? Thank you for watching. And for taking proactive control of your health journey. I am Dr. Michael Scott, and this has been Younger After 50.